So, good morning, everyone. Today topic is about wound healing. We'll go directly into the topic. So, the main agenda of wound healing, as a surgeon's point of view, is to create an environment for the wound to heal. Whether it can be a surgical wound or it's due to trauma or iatrogenic. So, what are the wound healing events that is happening in our body? So, first thing is after an injury, though the epidermis layer and the part of the tissue will be excavated. So what happens is the neutrophils and lymphocytes will come there and adhere to the surrounding inflamed area. So there starts your first thing, the coagulation. So after the tissues invasion, the coagulation process will transform. So the first thing is first cell to arrive there is neutrophil. Second thing is lymphocytes, and third thing is platelets. So after forming, these are the first initial inflammatory changes, and the inflammatory markers like TGF beta and platelet derived growth factor, that is PDGF. These things will come there, and initially it will stop the bleeding by arresting a fibrin clot. Then starts your, after 48 hours, starts your late inflammatory process, that is healing process. And the last, after 72 hours, there will be a remodeling process. So the remodeling process will be starting after 72 hours. So that will take, for the small wound, it will take some 1 week or 2 weeks or three, maybe up to 1 month. But the long process, like a patient presents you with a open fracture or loss of tissue, large surface area loss of tissue, so that patients will go for a remodeling phase for about 1 week or to 1 month. So these are the four phases. Initially, an injury will happen. Second thing, the cells will arrive there. The neutrophils and lymphocytes and platelets will arrive. They will form a coagulation cascade, and the late inflammatory process will happen. So the last thing is remodeling phase. These are the four phases you should know when the something is there asking for wound healing. So first thing, the injury where the blood vessels are disrupted, so that's resulting in bleeding from anywhere from the body. So there comes your hemostasis. The first goal is to achieve hemostasis in the healing process. So as I told you earlier, the cellular damage occurs. So whenever there is a cellular damage occur, the inflammatory process will be triggered. So there comes your cells like neutrophils and platelets and lymphocytes. So this platelets, lymphocytes, and neutrophils will form a hemostasis process resulting in fibrin. So fibrin and fibronectin from the migration of the inflammatory cells from the endothelial cells. So this indirectly will trigger the cytokines. So there forms your angiogenesis process. So what are the signs of inflammation? So there are 5 signs: erythema, edema, pain, and heat. So rubor, pallor, calor, this thing you should definitely know, signs of inflammation. So immediately after the injury, there is a the blood vessels will be vasoconstricted. So that there will be occurring the vasospasm due to the nitrous oxide release and the prostaglandins released by injured cells. So vasoconstriction is reversed only after 10 minutes by vasodilation. Now, so there comes your redness and warmth. So the microvenules will dilate and the gaps between the endothelial cells, resulting in vascular permeability. Plasma leaked out of the endovascular space. Leukocytes now migrate into the wound. So there comes your diapedesis other to the endothelial to the wounded tissue. So there will be alteration in the pH due to the breakdown in the tissue bacteria, along with the swelling causes pain. So neutrophils, macrophage, and lymphocytes. So these three components will be in the wound. So neutrophils first on scene engulf and clean up the macrophages, then eat them in the dye, releasing free radicals. and destructive enzymes into the wound, and the monocytes migrate into the extravascular space and turning into the macrophages. And macrophage is very important in the normal wound healing process. So macrophages eat bacteria, dead tissue, and cellular metalloproteinase will break down the damaged matrix. So macrophages as the source of cytokines that simulate the fibroblast production and collagen production. So these FGF, EGF are the inflammatory mediators that will be coming into the play after 48 to 72 hours. So it will be remain there in the tissue for 5 to 7 days. So what are the intermediate events that is playing in the role for wound healing? So that there comes your proliferation, that is mesenchymal cell chemotaxis and mesenchymal cell proliferation, angiogenesis, that is angiogenesis nothing but regaining of or restoring the blood supply to the particular area or particular organ, and epithelialization. So fibro proliferation is the all about the cells we are dealing with, fibroblast. So this fibroblast is the major mesenchymal cell involved in wound healing. So smooth, but the 80% there will be fibroblast and 20% will be smooth muscles. So these fibroblasts normally reside in the dermis. So epidermis and dermis. So it will be in the deeper layer and damaged by wound healing. So macrophage products are chemotactic. So the I told you earlier about the inflammatory media, platelet derived growth factor and EGF and transcytoid growth factor and interleukin 1. So lymphocytes as well. So these are the inflammatory mediators that is released by macrophages that aids in wound healing. So angiogenesis, that is reconstruction of the vasculature. So due to the damage, there will be high lactate levels and acidic pH and decreased O2 tension in all tissues. So cytokines directly stimulate the endothelial cells and migration and polymer required for angiogenesis. So FGF1 is the most important angiogenic. FGF1 is the potent angiogenic stimulant. So it will be aid in angiogenesis, and heparin is the important cofactor for the FGF. So last comes your epithelialization. So this is the last step in the intermediate events pertaining to the wound healing. So the process of epithelial renewal after this is the process of epithelial renewal after the initial injury. So particularly important in partial thickness injury, but plays a role in all healing. So partial thickness wounds have epidermis and dermis damaged. So with some of the dermis preserved, so the epithelial cells involved in healing come from the wound edges and sweat glands, sebaceous glands in the more central portion of the wound. So skin anatomy, coming to the skin anatomy. So epidermis is composed of multiple layers of epithelial and superficial to the dermis. The first layer above the dermis is the basal layer, which is composed of basaloid cells. The cells become more elongated as you go to the superficial stratum corneum. So stratum corneum is the mostly keratin and dead tissue. So in this diagram, you can see about the epidermis and the dermis, layers of skin. So in contrast to the incisional wound, and the cellular migration occurs over a short distance. So the incisional wounds are re-epithelialized in 24 to 48 hours. The sequence of events are here: cellular detachment, migration, proliferation, and differentiation. So first 24 hours, the basal layer thickness, then detach from the basement membrane and migrate to the wound as a monolayer across the denuded area. So generation of provisional basement membrane, which includes fibronectin and collagens of type 1 and type 5. Basal cells at the edge of the wound will divide 48 to 72 hours after injury. So the epithelial cells proliferation contributes to the new cells of the monolayer. So contact inhibition when the edges are come together. So these are the changes you can see in the normal incisional wound, that is iatrogenic wound. So coming to the last stage, late wound healing events. So the collagen plays a key role in late healing of the wound. So it is synthesized by fibroblast at the beginning of the fifth day after injury. So this rate increases rapidly and continues at a rapid rate for 2 to 4 weeks in most of the wounds. So as more collagen is synthesized, it gradually replaces fibrin as the primary matrix in the wound. So after 1 month, that is 4 weeks, so the synthesis declines and balancing destruction by collagenase. So this is the microscopic picture. You can see lot of collagen that has been formed within the first 4 weeks of injury. So what are the factors that will inhibit the collagen or that will promote the collagen production? So age, younger the age, more the collagen production. So tension, pressure and stress effects are the factors that decrease the collagen synthesis. So what are the factors that stimulate? So TGF beta glucocorticoids will, these are the factors will inhibit. So on the other 19 types are identified. So type 1 collagen is the most common found in all tissue, the primary collagen in the healed wound, and type 3 is in the early phases of the wound. Type 5 is the smooth muscle, type 2, type 11 in the cartilage, and type 4 in the basement membrane. So 3 polypeptide chains and the right hand helix. This is the biochemical structure of the collagen, and most polypeptide chains are used in collagen assembly or alpha chains. So this is the biochemical structure. You can see the 3 polypeptide chains and the right hand helix. So every third amino acid receives a glycine. So that's why glycine amino acid is very helpful in wound healing. So another critical component is hydroxylation of the lysine and proline within the chains. Hydroxyproline is necessary for this, and this requires vitamin C, iron, and alpha ketoglutarate and coenzymes. So last step is wound contraction. It begins approximately 4 to 5 days after wound healing. So represent the centripetal movement of the wound edge towards the center of the wound, and maximal contraction occurs 12 to 15 days, although it will continue longer if the wound remains open. So the wound edges moves towards each other at an average rate of 0.75 mm per day. So wound contraction depends on laxity of tissue. So as a buttock wound will contract faster than the scalp and the pretibial area. So wound shape is also a factor. So square the wound is the faster than the circular. So contraction of the wound across a joint can cause contracture. So can be limited by skin graft, full better, that is split, full, not a full thickness, that is a split skin graft. So the earlier the graft, the lesser the contraction. So splints are temporarily slows the contraction. The last stage is the terminal wound healing stage. So this is the remodeling phase. That's the most important phase. So after 24 days, the net accumulation of collagen becomes stable. Bursting strength is the only 15% of the normal at this point. So 3 to 6 weeks after the wounding, the greatest rate of increase was the 6 weeks, and that 80% to 90% of the eventual strength, and 90% of the skin breaking strength. The number of intra and intramolecular crosslinks between the collagen 5 increases dramatically, a major contributor to the increase in breaking the strength. So quantity of type 3 collagen decreases, replaced by type 1 collagen. So remodeling continues for 12 months. So scar revision should not be done prematurely. So what are the factors that disturb the wound healing? So infection and foreign body, hematoma, systemic like AIDS, diabetes, uremia, cancer, smoking, increased platelet adhesiveness, O2 carrying capacity, that is anemia, endothelial changes, and diminished amount of collagen deposition. So radiation, fibroblast radiated abnormal, blood vessels will be, collagen is synthesized in abnormal degree, so to the irradiated tissue causing fibrosis, damage to hair and sweat glands, and vitamin A has been used to counteract this. Malnutrition, old age, Again, diabetes, the immunosuppressive states like diabetes and the patient who's on steroids. So this can be reversed by taking vitamin A, that is 25,000 units per day. So hypertrophic scars and keloids. So excessive healing result in raised thickness, thickened scar will be more functional and cosmetic complication. If it stays within margin of wound, it is hypertrophic. Keloids extend beyond to the confines, original injury. Dark-skinned ages up to 40 wound within the pre-sternal and deltoid area are more prone for the keloid. Keloids are more familial. Hypertrophic scar develops soon after the injury. So hypertrophic scar may subside in time. Keloids and rarely do. So hypertrophic scar are more likely to cause contracture over the joint surface. So both form an overall increase in the quantity of the collagen synthesis. So no modality of treatment is predictably effective for the lesion. Thank you.